Well, Maryl, it's great to see you again here in this wonderful city of Prague. It's a city I know quite well and I have friends living here. I've visited many times. So,
well,
what about
lucky you.
Yeah.
It's gorgeous here. And I mean, I've been here several times. Once as an accompanying person to a meeting, and that's what's really nice because you don't have the meeting responsibilities, and I think this is my 4th meeting in Prague, but it's still great to be back and certainly good to see you, Paul.
Yeah. Well, last time I was in this city was 5 years ago, and I'm a bit of a cyclist these days in my retirement. And I started a cycle journey to Copenhagen from Prague with a group. So that was quite an undertaking, but fun. Yeah.
You're much more ambitious than I am. But so basically, I think that just to ask a question to start, what do you think has changed? I mean, you're kind of in the lung field, I'm in the heart field, and what has grown up in the lung field during the period of time you've been affiliated with the ISHLT?
Well, I guess I would answer that by saying lung transplantation became a clinical reality from an experimental procedure. I joined the field in 1987 when we did, I think, what was the first single lung transplant in Europe that was successful. In Newcastle, that was performed by Chris McGregor. I was the physician on the team. Funnily enough, he'd recruited me. I'd just been appointed to the faculty at the university in Newcastle. I was sitting in my office. My interest at that stage in research had been in lung cancer. He knocked on the door. He'd started a heart program, and he said, "Why don't we start a lung program?" And I said, "Well, that sounds like a good idea." And here I am now. So I've reflected on really the very early days of transplantation when things were hairy and uncertain and didn't even know if the UK government were going to support it. In fact, the first 3 transplants we carried out in Newcastle were funded by the people of Newcastle via a newspaper. So I've seen it grow from very early beginnings to what we think we know now. But there's still a long way to go.
Absolutely.
What about the heart field and your involvement?
Yeah, and I got started very early in the heart field too. I think that my first involvement with the heart transplant eventual recipient was in 1984. And I was at the University of Iowa at the time and had a patient come in who clearly had end-stage heart failure and kind of, what am I going to do? I was my first faculty year. I didn't know where to go with this. And somehow, probably in a more innovative thought than I would have now, kind of went and told him after I did his cath that, there's this thing called transplant. They do at this place called Stanford, and we should look into this for you. And so, fortuitously, his father said, well, half of the year I run a tax business out of Santa Cruz, California, close to Stanford. Look into the options of doing transplant, and bottom line, sent me the referral materials. I sent the referral materials out, and the patient went out there to get transplanted, then came back to Iowa, needed a doctor to help take care of him. And it's kind of like, okay. But fortunately, Stanford was very well set up at the time. And in fact, Sharon Hunt, who we all know and love in ISHLT, was really the person that kind of took me under her wing and had, if I had questions, I could call her, I could work with her. And then after that one, Iowa decided to start a heart transplant program after taking care of this patient and one other one. You know all about this, you should get involved. But it's been a wonderful field. I think that, kind of growing up with the field, I feel pretty comfortable with it. I know I still have a lot to learn, but it's something that I'm passionate about. And I think that's one of the things about transplant. People are either passionate about it or they get out because it is such a demanding field, both mentally, physically, academically, the whole thing. And you have to love the people that you are helping take care of and the people that you work with.
That's for sure, and there is a similarity between us in a way, because when I was a training fellow, just before I was appointed to the faculty, we had a patient who was under a great mentor of mine, Alistair Brewis. He wasn't a pulmonologist of a renown in the transplant field, but he was a huge figure in British respiratory medicine, as we call it, pulmonology. And he'd referred a patient down to Magdi Yaku with emphysema for transplantation, and I got landed with the job of
there
doing
you go.
the post-transplant. So that sort of kindled. So when Chris McGregor knocked on my door, I was already tuned to say, hey, that sounds like an interesting area to be in. Yeah.
So Paul, we've both kind of grown up with our fields, as we've talked about already, and you know, we have, particularly at this meeting, many junior people here, which I think is wonderful. That's the vibrancy of the society. But they're going to see a different world than we've seen. And what kind of things do you propose that they should do differently? How are things going to be different for them than it was for us?
I guess I would answer that first of all by saying there's tremendous changes already happening. For example, cystic fibrosis, the very end stage or diseases that lead to end-stage lung disease. The new knowledge, the molecular approaches to mechanisms of disease is creating therapies that are actually changing the natural history of the very diseases that we do lung transplantation for. So there are very, very few patients now with cystic fibrosis on waiting lists for lung transplants. Whereas in the early days, about a third of patients had cystic fibrosis. So that's already been a dramatic area. And I think we're going to see the same sort of thing for interstitial lung disease and maybe for some forms of COPD, particularly alpha-1 antitrypsin deficient emphysema. I think there may be new treatments along that will kind of reduce the need. And so that may sound like a kind of negative thing for transplantation, but there will always still be some diseases for which we don't crack the underlying mechanism and can treat. So it's important, I think, to really think about how we use the research findings and bring them into clinical care. That's one of the areas I feel in transplantation we haven't, certainly in lung transplantation, haven't quite been as good as we might have been. We've done a lot of research, a lot of good stuff, but it hasn't necessarily influenced dramatically and changed the way we use immunosuppression, for example. So one of the things that I think young people can do via the society is to have a dialogue now with our pharma partners, our industry. We need to work with them in terms of getting new pipeline therapies forward, because rejection, particularly chronic rejection or chronic allograft dysfunction, the many routes and mechanisms of that, the current armamentarium are not good at improving survival. And although survival has improved, there's still a long way to go. So that would be one area that I would suggest to our young people who I agree with you. They're the lifeblood of a society like this. They are our future. They are the society's future. Let's work with industry. Let's partnership. Let's speed up the development of novel approaches with our greater understanding and ability to understand not just the diseases that lead to the transplantation, but our control of mechanisms that affect allograft function post-transplant.
And I think we have a similar thing in heart, really, and I think that, you know, we've kind of made progress also in advanced heart disease, which is being included in the society now in a much bigger way than it was previously, particularly the mechanical circulatory support. But I always tell patients and my junior colleagues is my goal is to prevent people from needing transplant. So kind of going upstream a little bit. And there are patients that I would have seen when I first got involved in the field. I'd see them, they have a bad heart, the pump is down, and they're not feeling that bad, but okay, transplant is what we have to do. We've done a good job of actually coming up with different medical therapies to sustain them, in many cases make them better, but then they hit the point where they need a transplant. And we've made a lot of, you know, progress in early post-transplant survival with heart transplant. But similarly to what you expressed for lung, that long-term survival, those curves are still parallel. So there's still a lot to learn. And I think as people come into the field, you know, having them tackle that in ways that you and I may not have even thought about because of different technologies, different testing platforms. I mean, artificial intelligence for all things, predicting risk of rejection even, or what is the risk based on this, that, and the other thing. So I think that although we've made a lot of progress in the last 30, 40 years, I think that we're still kind of an infant field, and there's still a lot to go, a lot to gain, and so I think it is a bright future for people that want to get involved now, maybe even brighter than what we've had.
Yeah, I hear my colleagues chat about sometimes left ventricular assist device support versus heart transplantation. Where do you fit on that? Because there's so much development in that LVAD technology.
I think two things I would say. One of them is until we have a totally implantable system, I think the quality of life with a transplant is still generally better than the quality of life with an LVAD, although we've made progress in those lines. I think the other thing really is that clearly there's a role for LVADs in patients that are not transplant candidates or in patients for whom a donor organ is not available in time. And so I think that the LVAD space will always have that space. But I think that we're much closer to that than we used to be. And whether there'll ever be a trial, I don't know how you could randomize people between transplant and VAD. I mean, some of the classic VAD trials have been very difficult because randomizing people to surgery or no surgery when they're very, very ill is a very difficult thing to do, but has happened, and we've learned a lot because of that.
They're tough trials to do, but the information is you get glean is fantastic. So Maryl, here we are in 2024. We've both had many years of professional life in the field, but one always kind of looks to the future. Where do you see things moving? Where are going to be the big hits in cardiac transplantation?
No, I think it's a challenging question, and I always say my crystal ball is broken and I can't tell the future, but I think there are several areas that are going to be important. I think number one, being better at utilizing the donor hearts that are available, the gift of life that people provide. And I think there are disincentives in many ways to use hearts that may not be perfect, although we don't get perfect hearts anymore. When I first started in the field, I mean, if it wasn't perfect, we didn't take it. But now you need to. And I think some of the developments that are happening around, organ preservation, organ transportation, and those kind of things are probably going to change the future. Now, how fast and in what way, I don't know. I think that lungs ahead of us a little bit in terms of reconditioning the organ in an ex vivo, outside the body situation. I think that'll happen. And I think, xeno is not there yet, xenotransplantation, although, there is at least so far one successful kidney that's still going after a couple weeks, and there have been some hearts that we've learned a lot from. So I think with the donor shortage, we have to keep looking at other options. I don't think I'll live long enough to see a heart generated in a petri dish that then we can transplant, although there are certainly people that are doing studies of that based on cellular matrices and things like that. So I think some of it is probably organ donor availability, and then I think, as we've alluded to before, the management of the transplant recipient. What can we do to improve the long-term overall survival that will be beneficial both in terms of helping with donor shortage, but also helping with the quality of life of the recipient.
Okay.
And I don't know, what about in lung? Where do you think they're going?
Well, I think you're right. I think the way of preserving lungs and reconditioning lungs, EVLP, ex vivo perfusion, the way that it's historically been done was never, to my mind, that sensible. To make an organ ischemic and cold, those are two things that damage tissues. So it was already a sort of controlled damage experiment. So I think the lung perfusion, ex vivo perfusion, and other technologies are looking very good. I think we're moving in transplantation slowly but definitively towards I thought that personalized approaches are the way. You have to have a clear understanding of the underlying mechanisms leading to problems, and I think we're starting to touch that. And I think matching organs to recipients is something that we might even be using artificial intelligence to help us with. So I think the numbers issue is a very important one, and one that new mechanisms of preserving the lung prior to transplantation and reconditioning it, are certainly going to grow massively. And then I think an understanding in that individual patient why events are happening in that organ are likely to lead, providing we have the tools to then change that body response, injury response would be something. And I firmly believe one's only going to look at what's happening in other spheres to see that's really producing great results in other diseases. So that approach is one that I can see coming into transplantation.
And I think that's one of the things that's kind of a challenge we can provide to the upcoming generation. Is these are things that they need to work on in their careers to help future of transplantation become even better than it is today.
That's true, and I think I think that progress as a young researcher, it's always useful to have someone that you can go to and discuss a wise old owl, if you like. But it is important that, and I think it's important for us within the society to remind the society all the time that good mentorship is a very vital part of what a society like this should do. And I expect you have mentors who have helped you through the career. I certainly, from a medical student onwards in my final year, Duncan Geddes, who was an eminent pulmonologist in London, he was my clinical tutor as a student, and I thought, I want to be like him. And I'm not at all like him, but nevertheless, I think we may not look, we may not have done the same things,
correct,
but we have the same mentality, and that's been important. And I'd also cite John Gibson, who was a mentor to me, an eminent physiologist, which was important in the early days of lung transplantation. I know molecular medicine has taken over, but sound physiology was a very important early part. I would cite John as my mentor and then latter colleague, and he let me get on and play with transplants as a faculty member. And what about you then?
Well, and I think maybe the other thing is just to remind people that they can have mentors through transplantation societies or through their individual transplant programs, but also mentors outside the field. Because sometimes the way you grow and develop is somebody that's looking at things a little bit differently. And certainly when I started, and I know when you started, I didn't have a lot of heart transplant cardiology mentors. There weren't that many. We kind of got around a table and talked about it, and this is what we did. But I had some very, very strong general cardiology mentors. One by the name of Mel Marcus, who was a very outstanding coronary physiologist. Lou January, who actually has connections not only in medicine, but in the arts, which was also something that's important. And maybe that's the other recommendation, is to make sure that they maintain balance with their lives. Because what we do can be so demanding, and you've got to have something that just takes your mind off all of the things, even if they're good, but just have something to divert yourself from the stress and strain of what we do every day.
100% agree with that, absolutely. I always tried to maintain a life outside of my medical life. Many of my friends were not physicians or surgeons, and I deliberately mixed with them because that was, if you like, a little respite from because when we meet like this, we tend to talk about medicine and transplantation. And it's nice to step out occasionally, for sure.
Absolutely. Well, Pa, it's certainly been great visiting with you today, and the conference is just beginning, but I look very much forward to the rest of it. I'm sure it's going to be an exciting meeting, and I look forward to seeing you at future ISHLT meetings.
Indeed, and I think you will. I think we're in Boston next year.
We are.
And my wife's excited about that too.
There you
She
go.
likes Boston, so we'll be there.
Absolutely.